Hello and welcome back to Clinical Cases. Today we're going to be looking at the remaining cases that we were taught about within the urogenital block. So these include miscarriage, menopause, pregnancy and placental abnormalities, different types of urogenital cancer such as cervical, vulval, endometrial and ovarian cancer, gestational-trophoblastic disease or molar pregnancies, premature ovarian failure and fibroids. So let's get started by looking at miscarriage. So miscarriage is the natural death of an embryo or fetus before it's able to survive independently, and within the UK we classify this as before 24 weeks of gestation. The most common symptom of a miscarriage is vaginal bleeding, and this can occur with or without pain for the patient. What's really important to consider with a miscarriage is that the parent may undergo feelings of sadness, anxiety and guilt after a miscarriage, and therefore sometimes therapy is also necessary. There are several risk factors for a miscarriage, and the main one being an older parent. So as age increases of the parent, the more chance they are of having a miscarriage. There are other risk factors such as having a previous miscarriage in the past, exposure to tobacco smoke, obesity, diabetes, thyroid problems and drug and alcohol use. Around 80% of miscarriages occur within the first 12 weeks of pregnancy in that first trimester. And it's important to be aware of the classifications of a miscarriage. So an early miscarriage is defined as less than 12 weeks or within the first trimester. And a late miscarriage is defined within 12 to 24 weeks, so within the second trimester of pregnancy. What you really need to know about is a recurrent pregnancy. So this is referring to 3 or more consecutive losses of a fetus before 24 weeks. And this actually only occurs in 1% of women. It's also important to be able to differentiate between the risk factors for a normal miscarriage, which we just mentioned, and the reasons for a recurrent miscarriage. So recurrent miscarriage risk factors are these 8 here. And it's good to be aware of a little bit of information about each one, because you can then link the cause to the condition. So increasing maternal age, if a woman's delaying the pregnancy, their oocytes are aging and therefore more likely to be abnormal. Women only have the same oocytes throughout their entire life as they do when they're born, and therefore the older they get, the more aged the oocytes are and more likely to be abnormal. A structural uterine abnormality, so this could be congenital or acquired, so this could be referred to fibroids, which we'll talk about later, or it could simply be defects in the uterine development. Thrombophilia is also an important one to be aware of, so this is where the blood has an increased tendency to form clots. Again, this can be inherited or acquired. Endocrine causes, so poorly controlled diabetes and thyroid disease is an important one, but this also links to normal miscarriage, not just recurrent miscarriage. Genetic factors, 70% of miscarriages are due to sporadic chromosomal abnormalities, so they are random events and unlikely to occur, however a small portion are due to genetic factors. Antiphospholipid syndrome, so this is an autoimmune condition, also referred to as sticky blood. This can however be treated with aspirin. Also there's cervical weakness, so this is where the cervix dilates too early, causing the loss of a fetus, so the expulsion of a fetus too early, and this is usually a cause of late miscarriage. Lastly, the last cause essentially is unexplained. Often there's no cause for a recurrent miscarriage, which can be especially quite traumatic for the parent, but there's very little evidence to support this or why this happens. Next we were taught about the menopause, so this is when a woman stops having periods and is no longer able to get pregnant naturally. Periods usually start to become less frequent over a few months or years before they stop altogether, and sometimes however they can stop suddenly. The menopause is a natural part of ageing, however. It usually occurs between 45 and 55 years old, and the average age in the UK for a woman to reach menopause is around 51 or 52 years old. Treatment for the menopause in particularly bad cases can be treated with HRT, and this can be given orally or transdermally or topical or intrauterine system. However, this is only if the symptoms are particularly bad. And you can classify the symptoms from acute clinical symptoms to medium to long-term implications. It's also important to be aware of the 3 stages of menopause, so premenopause, perimenopause and postmenopause, in order to understand the stage that the patient is at. Next, we were taught about pregnancy and placental abnormalities. So in terms of pregnancy abnormalities, you've got an ectopic pregnancy, which is where the egg implants outside of the womb. This most commonly occurs within the fallopian tubes due to the fact that this is where the egg is fertilized within the ampulla, and therefore, normally, if you have an ectopic pregnancy, it will be in the fallopian tubes. However, it's important to know that an ectopic pregnancy, referring to the word ectopic, is not where it's supposed to be. A postpartum hemorrhage, so this is excessive blood loss from the genital tract after delivery. This can be classified by how much blood loss there is and the method of delivery. Again, know that it's divided into primary and secondary types. So primary postpartum hemorrhage is within the first 24 hours after delivery, and secondary PPH is from day 1 to day 6. From day 1 to week 6, postpartum, and know the causes for both of these as well. In terms of placental abnormalities, these are a little more interesting. So you have placenta accreta, and this is when all or part of the placenta attaches abnormally to the myometrium, so that's the muscular layer of the uterine wall. There are 3 grades of abnormal placental attachment. These are placental accreta, placental increta, and placenta percreta, and these are described nicely in this little picture here. You only need to know a little bit about each one. Placenta accreta is the main one to be aware of. Placenta previa is also quite important. So this is an obstetric complication in which the placenta is inserted partially or wholly into the lower uterine segment. So essentially it's inserting on top of the cervix or covering the cervix, and this can cause severe bleeding during the pregnancy and the delivery. What's really important about this is it does prevent vaginal delivery, so therefore you'd have to go to a C-section in this case. Next, we were taught about different types of cancer. So there's cervical, vulval and endometrial covered on this slide. So cervical cancer is a cancer arising from the cervix. It's due to abnormal growth of cells that have the ability to invade or spread to other parts of the body. That's your general definition of cancer. Early on, typically there are no symptoms for the patient. However, later on, they may suffer from abnormal vaginal bleeding, pelvic pain, or pain during sexual intercourse. It is in 90% of cases caused by HPV, which is a virus. And it's most common within women aged 30 to 45, so most common in middle-aged women. Vulvar cancer, this mostly occurs in elderly women. It can occur in younger women, but mostly it does occur in older women. It usually presents with a vulval lump or ulcer, and it is usually very painful for the patient. Endometrial cancer can be split into 2 types. So endometrial cancer is a cancer that arises from the endometrium. So the endometrium is the lining of the uterus of a womb. The first sign is most often vaginal bleeding, not associated with any menstrual period. Other symptoms can include pain when urinating or during sexual intercourse, or pelvic pain, so quite similar symptoms to that of cervical cancer. Endometrial cancer occurs most commonly after the menopause, and approximately 40% of cases are actually due to obesity. It's important to know the differences between endometrial type 1 and type 2 cancer, and the main difference here are the types of cancer. So type 1 cancer, you'd expect endometrioid or mucinous cancer. Type 2, you'd expect uterine serous clear cell and carcinoma sarcoma. So be aware of these types and roughly what they are and what the implications are as to where the cancer would be. This is a nice little diagram that I found, just showing the kind of the pathophysiology and the histology as well of a uterine cancer. An endometrial cancer. Next we have ovarian cancer. So this is a cancer that you need to know quite a little bit about. So it's a cancer that forms in or on an ovary. When the process begins, again, there may be no early symptoms. However, the symptoms will develop as the cancer progresses. It's important to be aware of the 3 locations that an ovarian cancer can arise, or the 3 most important places that they can arise. So most commonly they occur within the epithelial layer. This is the most common type, and they predominantly occur in older women, so women aged 50 to 80 normally. As with most cancers, they can be benign, borderline or malignant. And there are 3 types. So what's important about these is knowing the 3 categories of ovarian cancer, and then knowing the types of those cancer. So it's almost like types and subtypes. Germ cell cancers occur in younger women, predominantly those under 30. These can be benign or malignant. They present with abdominal swelling and pain. That's how most of these cancers will present, with abdominal swelling and pain. And the prognosis is different for each of these cancers. So for epithelial cancer, this is usually quite incurable once it's spread beyond the ovary, and patients really only have a mean survival of 3 years. Germ cell cancers, these have a generally very good prognosis, and most of them are cured. The last type are sex cord or stromal cancers. These also have quite a good prognosis, but they can reoccur locally. These, however, are more rare and can occur at any time throughout life in older and younger women. and some of them do secrete hormones, extra hormones such as estrogen and progesterone, leading to some side effects, which they also may present with alongside the abdominal swelling and pain. In terms of investigation for this, the main investigation is a calcium 125 test, which can be done by testing the blood. Next, we learnt about gestational-trophoblastic disease, also in molar pregnancy. So gestational-trophoblastic disease is the name for abnormal cells or tumours that grow from a tissue that form in the womb during pregnancy. It can be non-cancerous or cancerous. Essentially, GTD is an overall name for molar pregnancies, persistent trophoblastic disease, choriocarcinomas, and placental site trophoblastic tumours, so it kind of refers to all of those. The main one that we need to know about is molar pregnancies, and these can be divided into complete and partial are much more common than complete. It's important to know the differences between these two and how they are formed. So a complete molar pregnancy is when an empty egg is fertilized, and a partial molar pregnancy is when a normal egg is fertilized by one of the following. So it's important to know about those. The risk is scored with a FIGO system or FIGO system, and however, these do normally have a very good prognosis. POF is the next thing we were talking about. So premature ovarian failure is when a woman's ovaries stop working before she's 40, and it's important to distinguish POF from premature menopause. So with premature menopause, your periods stop before the age of 40 and you can no longer get pregnant. The cause can be natural or it can be a disease. With POF, some women will still have occasional periods and they may even get pregnant. And the cause is usually unknown for POF. In terms of what they will present with, usually they will present with missed periods as the first sign, and later symptoms will be those of a natural menopause, such as hot flushes, night sweats, irritability, poor concentration, decreased sex drive. The risk factors are age, so it usually occurs between the ages of 35 and 40, which can lead people to think it is premature menopause. However, it's not. And it's important to investigate it properly in order to differentiate between the two. It can come with complications, so infertility, osteoporosis, depression and anxiety, heart disease and dementia. Infertility, it does affect it, however, like we just said, women still can get pregnant with POF, but it makes the chances less likely overall. Fibroids are the last thing we were taught about, so these are non-cancerous growths that develop in or around the womb. The growths are made up of muscle and fibrous tissue and they vary in size. This diagram here is particularly useful for understanding where the fibroids can be. Essentially, fibroids are more frequent with increasing age and they usually do shrink after the menopause, and this is due to the fact that they're linked to hormones. So estrogen and progesterone promote the growth of fibroids, so it makes sense because after the menopause you have a decrease in the levels of estrogen and progesterone and therefore a decrease in size of the fibroids. The treatment for fibroids can be medical or surgical, so we can treat them with GnRH analogues or anti-progesterones, or the treatment can be surgical, so a myomectomy or a hysterectomy can also be performed. The prognosis is generally very good. Occasionally there will be a few major problems, however this is only in a few cases, and normally the prognosis overall will be quite good as a general rule of thumb. That's everything for this video. If anyone does have any questions or comments, please do feel free to leave them below, or alternatively drop me a message personally. I'd love to hear from you and see what you think of the videos. That's everything for today. Thank you very much for listening.